Done. Good morning, everyone. The topic is endocrine emergencies. I am going to discuss about thyroid emergencies. Let's start with case scenario. 32 years old woman presents to the emergency department with a high fever, palpitation, and altered mental status. On examination, her pulse rate was 145 per minute. Tremors present. Her hands are moist, and her blood pressure shows widened pulse pressure. On eye examination, shows exophthalmos. So what it could be? Back row. Any guesses? Any idea? I give you another clue. She is a case of known case of Graves' disease. Sorry, thyroidoxicus. Yes, as we all know, it's a case of thyroid storm. So the most common cause of thyroid storm is Graves' disease with non-compliant medication. But the most common trigger factor is infection. So what is thyroid storm? It's an acute condition which is life-threatening exacerbation of thyroidoxicosis characterized by severe hypermetabolism and decompensation of multiple organ systems. And if untreated, it will be end up in mortality. So, as we all know, all the endocrine emergencies will be triggered by infection, most probably. As all the any kind of surgery and trauma, myocardial infarction, and diabetic ketoacidosis, and thyroid drug withdrawal. So it will lead to release of increased release of thyroid hormones. So with the upregulated beta adrenergic receptors and catecholamine surge, the tissue sensitivity towards the thyroid hormone will be increased. So that all the systems will be involved. So get into the individual systems. In CNS, patient may develop agitations and delirium. Seizure may develop. If untreated, it will be end up in coma. In CVS, patient may develop tachycardia and atrial fibrillation. In most cases, ends up in shock. In GIT, patient may develop diarrhea, dehydration, and congestive hepatopathy may occur. If untreated, liver failure may occur. In metabolic, there may be hyperpyrexia. So this is a schematic diagram of thyroid storm. So which are all the systems involved? So let's get into the clinical features. There may be high fever more than 40 degrees Celsius, severe tachycardia, arrhythmias, and heart failure, agitations, delirium, psychosis, coma. In GIT, there may be nausea, vomiting, diarrhea, dehydration, and shock. So there is Burt's Wadsofsky point scale, which is used to determine the conditions by clinically, it's a thyroid storm. With the clinical symptoms. The clinical symptoms based on the systems which involved in thyroid storm, those are CVS, GIT, and CNS, and also precedent history was included, and temperatures also included. If the total value is less than 25, it's not like thyroid storm. If it is 25 to 45, it's an impending storm. If it is more than 45, definitely it would be thyroid storm. So what are all the investigations to be taken? Of course, thyroid function test has to be taken on ECG to rule out any cardiac related tachyarrhythmias, and CBC, LFT, electrolytes has to be taken, and blood cultures has to be taken if there is any leukocytosis found. So go on to the management. Have to establish the patients with the supportive care, ABC, airway, breathing, and circulations with O2, IV fluids, and cooling therapy. So we have to block the synthesis of thyroid hormones and also block the release. And we have to reduce the effects of thyroid hormones by beta blocker. And steroids plays a major role. Also, precipitate history has to be treated. So what is the drug of choice? Propylthiouracil. It's a drug of choice is propylthiouracil. It's a 600 to 1000 milligram loading dose, followed by 200 to 300 milligram 6 hourly. To block the release of thyroid hormones, we have to give iodine. If it is glucose iodine, it's 8 to 10 drops, and orally every 6 to 8 hours has to be given. If it is saturated solution of potassium iodide, 5 drops orally every 6 to 8 hours has to be given. Propranolol 40 to 80 milligram per oral, 6 hourly has to be given. Hydrocortisone 100 milligram IV 8 hourly given. There is a two phenomenon, Jod-Basedow effect and Wolff-Chaikoff effect. First one is both conditions were treated by excess iodine. Jod-Basedow effect is iodine-induced hyperthyroidism. Wolff-Chaikoff effect is to remember, it's a name itself called Wolff-Chaikoff. So there may be thyroid hormone will be reduced, synthesis will be reduced in Wolff-Chaikoff effect. Jod-Basedow seen in abnormal thyroid gland, which is free from pituitary control. So endemic goiter and Graves' disease and toxic multinodular goiter, if they were treated with ingested with extra iodine, there may be iodine-induced hyperthyroidism. which Wolff-Chaikoff effect. It's seen in thyroid gland, which is there may be a normal thyroid gland or a Graves' disease may be present. If it is normal thyroid gland, hypothyroidism will be recovered after 10 days. If it is autoimmune conditions like Graves' disease, hypothyroidism will be persist. So refractory thyroid storm. Refractory thyroid storm, even after treatment, there may be the excess thyroid hormone. It's called a refractory thyroid storm. So it will be treated by plasma paralysis, dialysis, and cholestyramine. If not controlled, surgery will be planned. So it's an important chapter in this topic, thyroid storm in pregnancy. So as all we know, infection and surgery and withdrawal of antithyroid hormones plays a major role in precipitating the thyroid storm in pregnancy. Clinical features, as we all discussed earlier, there may be fetal tachycardia, distress, preterm labor. There is a risk of neonatal thyrotoxicosis due to thyroid TSS receptor antibody may cross placental barrier. So what antithyroid can be used in pregnancy? Any idea? Final year? Sir, UG. So can we use the same drug in all 3 trimesters? Yes or no?
So what are the antithyroid drugs? You say that first.
So what can be given in first trimester? Sorry, any one of you? Okay, it's propylthiouracil will be preferred in first trimester. It's already said 600 to 1000 milligram loading dose, followed by 200 to 300 milligram 6th hourly. And second, rest of the IN period will be treated with methimazole. Let's get into the second case. A 72 years old female with a history of hypothyroidism was brought to the emergency department with confusion and progressive lethargy and hypothermia. On examination, she was drowsy and bradycardia, hypotensive, hypothermic, hypoventilating with SpO2 88% and room air. Her skin was dry and pale, face puffy with periorbital edema, which is non-pitting, and reflexes were delayed. So there was no goiter. So what it could be? So there is hypothermia and there was no goiter. So what it could be? What's the diagnosis probably? So it's a case of myxedema coma. It's an extreme life-threatening expression of hypothyroidism characterized by progressive mental deterioration, hypothermia, and slowing of multiple organ systems. Despite its name, coma is not always present. The hallmark is altered mental status in a patient with severe hypothyroidism. So as we all know, all the endocrine emergencies will be precipitating factors. There is an infection or a myocardial infarction, stroke. Here, in previous conditions, there may be hyperthermia. Here, cold exposure, there may be hypothermia. So sedative and trauma also precipitating factor. So due to that conditions, thyroid hormones will be reduced. So let's get into the individual systems. In CNS, due to decreased cerebral metabolism and hyponatremia, patient may develop lethargy and stupor. In worst cases, ends up in coma. In CVS, due to bradycardia and decreased cardiac output, patient may develop shock. In respiratory system, there may be hypoventilation and hypercapnia, maybe develop respiratory acidosis. So metabolic conditions, they may be develop hypoglycemia and hypothermia. So clinical features, in myxedema coma, there will be hypothermia, bradycardia, hypotension, stupor, confusion, coma may occur, hypoventilation, hyponatremia, hypoglycemia, and puffy face, and macroglassia and dry skin. So investigations, so we all know the thyroid functions, it's mandatory, and ABG to rule out any acidosis or alkalosis, and hyponatremia, serum electrolytes has to be taken, and hypoglycemia to be ruled out. ECG also has to be taken to rule out low voltage and bradycardia. Here, patient has to be stabilized with the basic supportive management. After that, we have to give IV levothyroxine. In India, IV levothyroxine is not available, so we are giving oral levothyroxine. So IV hydrocortisone also plays a major role. 100 milligram 8th hourly has to be given, and electrolytes imbalance also to be corrected. If there is any infection, antibiotics should be given. So what is thyroid storm and myxedema coma? Thyroid storm is both the conditions are two extreme entity, and thyroid storm is very high. There will be very high fever. In myxedema coma, hypothermia will be there. In thyroid storm, severe tachycardia and atrial fibrillation arrhythmia may be seen. In myxedema coma, there is bradycardia and hypotension seen. In thyroid there is agitations and delirium and seizures may occur. In myxedema coma, there is respiratory depression, hypotension, hypercapnia, maybe lead into coma. In GA symptoms, in thyroid storm, nausea, vomiting, diarrhea, abdominal pain, sweating, tremors will be occur. In myxedema coma, there is dry and poor skin and hair, weight gain and constipation may be there. Thank you all.
Thank you, Raghu, for enumerating the clinical features as well as the management of thyroid emergencies, namely the myxedema coma as well as the thyroid storm. Simply putting, the evening you will be cultural, it is like thyroid storm, having palpitations, sweating, and all kind of delirium. One fellow came with seizures after cultural during my DAP. The myxedema coma is like sitting in the medicine class 2 to 3.